Welcome to the deep dive, your shortcut to being well-informed.
Yeah.
Imagine trying to understand a really complex structure, maybe like a building, not just from photos, but by actually flying through it in 3D, slice by slice. Well, that's kind of what radiologists do with CT scans. They navigate hundreds of these image slices to build up a full picture in their mind.
It's incredibly detailed work.
Yeah.
Very labor-intensive.
And even for experts, spotting every tiny little thing in that huge amount of 3D data, it's challenging. Sometimes errors can happen.
Absolutely. It takes immense cognitive skill, that spatial reasoning. You're not just seeing something. You need to know exactly where it is, how it relates to everything around it, how it extends in 3D.
Right.
It takes years of training to get good at that. And obviously, the stakes are incredibly high.
For sure. And naturally, this is an area where AI researchers see a chance to help out. We've seen amazing progress with these multimodal large language models, MLLMs, the ones that can look at images and generate text. Think about writing a medical report from a scan or answering questions about it. The potential seems huge for speeding things up and assisting doctors.
Oh, it really is. And these MLLMs, they've gotten really good, especially with 2D images, things like chest x-rays. They can look at that flat image and write surprisingly good reports.
And this is the key thing. A CT scan isn't flat.
Right, yeah.
It's a true 3D volume.
Exactly.
And that third dimension, that depth, that's where things get really tricky for most AI models currently.
Yeah, the models built on 2D tech or even some of the earlier 3D approaches, they sort of struggle to really get the volumetric detail, the continuity of anatomy as you move deeper into the scan along that z-axis.
So they might look at slices one by one or just kind of summarize chunks of 3D data in a way that it loses important spatial information?
Precisely. And that limitation means they can easily miss subtle but really important findings. Or worse, they might just invent things. We call them diagnostic hallucinations. It happens because they don't have that deep grasp of the actual 3D reality of the scan.
Okay. And that brings us right to the heart of this deep dive. We're going to unpack a recent paper that proposes a really interesting, kind of clever new way to tackle this exact problem. Getting AI to truly understand 3D medical volumes and language together. It's called HSENet, that's HSENet, a hybrid spatial encoding network designed specifically for this 3D vision language challenge.
I think of it as a new structure, really, built from the ground up to handle the complexity of 3D medical scans better than what's come before.
So our mission today is to guide you through this research, pull out the really important ideas so you can get up to speed quickly on what HSENet is, how it works, and why the results look so promising. Let's start with just setting the scene a bit more on why interpreting 3D data is so tough in the first place.
Right. So, yeah, 3D CT scans were revolutionary. It gave us this amazing depth. But the human job of reading them, still incredibly challenging. Radiologists aren't just, looking at pictures. They're mentally rebuilding that 3D space, trying to connect findings across maybe hundreds of slices. It's complex.
And like any complex human task, it's open to perceptual errors, maybe fatigue, especially with just the sheer volume of images they have to look at.
Exactly. And that difficulty is why AI help is so attractive. As you said, these multimodal LLMs show a lot of promise for generating reports, answering questions about the scans.
But the big hurdle we keep hitting is that most of these really powerful MLLMs, they were primarily trained on huge data sets of 2D natural images, cats, dogs, landscapes, and text.
Yeah.
Their vision parts aren't really built for the unique spatial complexity of a 3D medical volume.
Right. And trying to just sort of adapt 2D methods like processing slice by slice or using some of the earlier, simpler 3D approaches, it just doesn't capture that crucial volumetric detail. You lose the sense of shape and how things connect in 3D. The paper points out two main problems with existing methods trying to do this 3D vision language stuff. First is a problem with visual perception itself.
Okay.
Often, the vision encoders they use are based on architectures, like CLIP-style ones that were pre-trained on those natural images we mentioned.
So using models good at spotting cats to find tiny lung nodules seems like a mismatch.
It is, and critically, the amount of data available to train these models specifically on paired 3D medical volumes and their reports is minuscule compared to natural images.
How small are we talking?
Well, the paper mentions maybe around 0.05 million 3D volume report pairs compared to like 400 million plus image text pairs for natural images.
Wow, okay, that's a huge difference.
It is, and that data scarcity really limits how well these encoders can learn to pick out the subtle but clinically vital details in a scan. They might recognize a general pattern but not grasp its specific medical meaning or importance.
Okay, so problem one, limited perception due to scarce, specialized data and maybe the wrong kind of initial training was the second big issue.
They call it compromised semantic projection. This is all about taking the complex visual information from the 3D scan and translating it or projecting it into a format the language model can actually understand and use, like turning the picture into tokens.
Kind of bridging the gap between the 3D image and the words the LLM uses.
Precisely. And the current ways of doing this, compression and translation, things like simple pooling methods or even standard components like a Q-former, they tend to throw away a lot of the essential spatial and geometric detail from the 3D structure.
So they might tell the language model something is there, but not exactly where it is in 3D or how big it is or what it's next to.
Exactly that. It loses that crucial spatial context. And if the LLM doesn't have that precise spatial information, it's going to struggle to write an accurate report or answer a question like, is the nodule in the upper lobe or the lower lobe? It leads to those unreliable outputs, the hallucinations.
Okay, so the core challenge is twofold. First, seeing the important details in scarce 3D data. And second, communicating that complex 3D information to a language model without losing the spatial context.
Spot on. And this is exactly where HSENet tries to make a difference.
So tell us about HSNet's approach. How does it try to overcome these limitations?
Its core idea is a framework designed to, first, perceive those rich 3D visual cues more effectively, and second, project them into the language space while preserving that essential spatial information.
And it uses a hybrid strategy, you said, centered around two main components.
That's right. Dual 3D vision encoders and something they call a spatial packer.
Dual encoders. Why two?
It's actually pretty intuitive, kind of mimics how a human expert might look at a scan. One encoder focuses on the big picture, the overall global volumetric context, the general anatomy, any large findings.
Okay, the overview.
Exactly. And the other encoder focuses on fine-grained local details, the specific patterns, the subtle things within smaller regions. They work together in parallel to get a more complete understanding.
Like zooming in and out. And the spatial packer, what's its role?
That's the critical link, the bridge between that improved 3D vision understanding and the language model. Its job is to take all the high-resolution 3D features that the two encoders have extracted and efficiently condense them down into a compact set of informative tokens that the language model can actually process. But, and this is key without losing those vital spatial details that other methods often discard.
Okay, that sounds promising. Let's dig into the how. How does HSENet actually train these encoders to see 3D so well? They mentioned a dual-stage pre-training process.
Yes, and it's quite neat because it's informed by how clinicians work. Get an overview first, then dive into the details. HSENet learns similarly in 2 stages.
Stage 1 is called 3D Volume Report Contrastive Learning. What's happening there?
So in this first stage, they train the global encoder, the one focused on overall structure. It learns by trying to match the representation of an entire 3D scan volume with its corresponding text report.
How does it match them?
It uses contrastive learning. Basically, it learns to pull the correct volume report pair closer together in this kind of abstract representation space while pushing incorrect pairs further apart. This teaches the model to understand the overall gist, the main findings described in the report, as they relate to the whole scan. It's about the macro level.
Got it. Stage 1 gets the big picture, then stage 2. This sounds interesting. 2D enhanced 3D cross-modal contrastive learning. Using 2D to help 3D. That seems a bit counterintuitive.
It does sound it, but it's actually one of the really clever parts. See, while the goal is 3D understanding, radiologists are incredibly skilled at reading the individual 2D slices that make up that 3D volume.
Right, they scroll through them.
Exactly. And those 2D slices, which you can easily get from the 3D data, are packed with diagnostic information. The paper cleverly leverages this existing expertise encoded in the 2D views.
Ah, okay. So it's not throwing away 3D. It's using the 2D slice as a kind of guide within the 3D volume.
Precisely. The second encoder, the one for local details, they call it the 2E3 encoder, gets refined in this stage. Instead of just looking at raw 3D chunks, it looks at features from tiny 3D patches. Then, through something called cross-attention, It makes these 3D patch features interact with features extracted from the corresponding 2D slices.
Okay, cross-attention. Can you break that down simply? What's it doing here?
Think of it like the 3D encoder is looking at a small 3D patch, and it asks the corresponding 2D slice view, hey, based on what you see in 2D, how important is this little 3D region I'm looking at?
Oh, here.
The cross-attention mechanism allows the information from the 2D features to effectively score or weight the importance of the different 3D patches.
So the 2D view, which might have clearer diagnostic clues sometimes, essentially points the 3D model towards the most relevant areas within the 3D structure. That is smart.
It is. This guidance, coming from readily available 2D slice information, helps the 3D encoder learn to focus its attention and feature extraction on the spots most likely to contain important findings. It refines its understanding of local, detailed anatomy.
And they also mentioned a semantic consistency loss in this stage. What's that for?
Yeah, that's important for keeping things stable. While you're fine-tuning this local detail perception using the 2D hints, you don't want it to suddenly contradict the broader understanding of the whole scan that was learned back in stage 1.
Right, you want them aligned.
Exactly. This loss function helps ensure that the refined local features stay consistent with the overall meaning, the global context of the scan.
Okay, so we have these dual encoders learning to perceive 3D from the big picture down to the details, with some clever guidance from 2D views. Now, once they've got these rich 3D features, how does that spatial packer turn them into something the language model can actually work with?
Right. So the challenge now is you have this potentially huge amount of detailed, high-resolution 3D feature information from the encoders. You need to condense it way down into a small, manageable number of tokens for the LLM.
Without losing the critical spatial layout. That sounds tricky. Like summarizing a complex 3D map into just a few bullet points without messing up where things are?
Exactly. And that's where the spatial packer's hybrid approach is key. It doesn't just, average everything out. It uses 2 different levels of representation simultaneously.
Okay.
It uses high-resolution voxel embeddings. Think of these like representing tiny 3D pixel regions, capturing fine details, and also lower-resolution point embeddings, which represent broader areas but are designed to retain spatial context.
So tiny detailed bits and larger summary markers.
Kind of like that, yeah. And the crucial part is how it connects them. They use a mechanism called Voxel2Point Cross-Attention, or V2PCA.
More cross-attention. What's this one doing?
This mechanism explicitly injects the detailed spatial information from those high-resolution voxel embeddings into the lower-resolution point embedding.
So the summary markers are actively grabbing the spatial layout information for the detailed bits they represent.
Precisely. It allows the compressed point representation to inherit and hold on to the rich spatial clues from the detailed voxel regions it's summarizing. The end result is a compact set of what they call spatial visual tokens. These tokens can be processed efficiently by the LLM, but crucially, they still contain enough spatial information for the LLM to reason accurately about locations and relationships within the 3D scan. That info has been preserved during the packing.
That makes a lot of sense conceptually. So that's the theory behind HSENet. How did it actually do when they tested it on real medical data?
They put it through its paces on several standard 3D CT datasets. They use CT rate for tasks like medical image text retrieval and generating reports, then red genome chest CT for medical visual question answering, or VQA, and they did an extra check on a dataset called BIMCVR for report generation just to see how well it generalized.
Okay, let's start with the results for image text retrieval. This is like finding the right scan for a report or the right report for a scan, right?
Yeah, or even finding scans that look similar to each other in 3D. And in these tasks, HSENet showed a really significant jump in performance. Using its full setup with both encoders, it consistently outperformed the previous best methods across all the retrieval variations: report to volume, volume to report, and volume to volume.
Give us a feel for the improvement. Any standout numbers?
Well, for report to volume retrieval, finding the right scan from a text report, their 2E3 vision encoder, the locally focused one, hit 39.85% on a metric called R at 100.
R at 100. Meaning the correct scan was in the top 100 results nearly 40% of the time?
Exactly. And that was a jump of almost 6% plus 5.96%, specifically over the next best method they compared against, M3D CLIP.
Nearly 6% improvement is pretty substantial in these benchmarks. What does good retrieval performance like that actually tell us?
It suggests the model is learning really good discriminative features that capture the unique essence of both the text reports and the 3D volumes, allowing it to match them up accurately. And the strong results on volume-to-volume retrieval, finding similar-looking scans, also hints that it's picking up on clinically relevant patterns related to pathologies, not just generic visual similarities.
Did the ablation studies back this up? Where they take parts away to see what matters?
Yes, absolutely. And one really key finding related back to that 2D guidance in the pre-training stage.
Right. They compared using the 2D slice features to guide the 3D patch scoring versus using features derived just from the text report. And using the 2D dual cues was significantly better.
Okay.
This really backs up their idea that getting diagnostic hints from the 2D slices is a powerful way to refine those local 3D features. They also show that removing that semantic consistency loss hurt performance, confirming it helps keep the learning stable. And they had those cool visualizations, didn't they, showing where the model was looking in 3D.
Yeah, figure 3 in the paper is great for this. It visually shows that the 2E3 encoder, the one refined with 2D guidance, learns to assign higher importance scores to the 3D patches that are anatomically significant or likely contain disease, and lower scores to less relevant areas like background or uniform tissue. It shows it's learning to focus intelligently.
Very cool. Okay, next big task. Report generation. This feels like the most direct clinical application. Can it write a decent preliminary report from a scan?
And here again, on the CT rate dataset, HSENet achieves state-of-the-art results across the board. Not just on standard language metrics like BLEU and rouge, which measures similarity to human reports, but crucially also on a metric called rate score, which is designed specifically to evaluate the clinical relevance and accuracy of the generated medical report.
That clinical score sounds important. What were the numbers like there?
For language quality, they reported 24.01% on BLEU4, which was a big jump, over 8% better than another recent model, Med2E3. And for clinical relevance, the rate score was 64.99, which was over 3% better than Med2E3.
So significant gains in both how well the report reads and how clinically accurate it is. Why do they think HSENet did so much better here?
The paper argues it comes back to their core design. Older foundation models often struggle with the true 3D complexity. HSENet's approach perceiving the 3D volume effectively with those dual encoders and then carefully projecting that spatial info with the spatial packer seems to handle the 3D structure much more robustly. It's not just trying to adapt 2D methods.
Did the ablation studies for report generation confirm that the spatial packer was key?
They did. When they swapped out their spatial packer for other ways of bridging to the LLM, like using a standard Q former or just simple pooling, the performance dropped noticeably.
Okay.
It really suggests that the spatial packer's ability to preserve that spatial structure during the compression step is critical for the language model to then generate accurate descriptions of where things are in the report.
And using both encoders was better than just one?
Yes. Using both the global and local encoders together gave better results than using either one on its own. It confirms they provide complementary information needed for a complete report.
There's that striking example in Figure 4 comparing generated reports, right?
Oh, yeah, it's very telling. It shows a report from a previous model, Med3D VLM, next to one from HSENet for the same scan. The Med3D VLM report has clear errors, mentions things inaccurately, looks like those hallucinations. HSENet's report, though, is much more grounded in the 3D reality. It correctly identifies specific organs like the adrenal glands, describes the thoracic aorta accurately. It really highlights the difference that better 3D understanding makes.
And they also tested on that other data set, BIMCVR, to check generalization.
That's right. And this was interesting because they only pre-trained their visual encoders on the first data set, CT rate. For BMCVR, they kept the encoders frozen and only fine-tuned the spatial packer and the language model parts.
Okay.
Even with that setup, HSENet still came out on top compared to other models, some of which might have been fully trained on BIMCVR.
So the features learned during pre-training are actually quite transferable. They capture fundamental spatial patterns.
It strongly suggests that, yes. For instance, they saw over a 14% improvement in the BLEU1 score compared to another model, E3D-GPT, on that dataset. It shows their visual learning strategy is pretty robust.
Okay, final task area, medical VQA, asking specific questions about the scan, often about location or relationships between things.
HSENet showed strong improvements here too, especially on questions that really required spatial reasoning. It outperformed previous methods, getting higher accuracy on questions about both big anatomical areas like the lungs or heart, and more precise locations like a specific part of the lung.
How much better was it on VQA?
For major class accuracy, it hit 73.60%, which was almost a 2% gain over Med3D VLM. The paper also notes that the 2E3 encoder, the local detail one refined by 2D, was particularly important for these VQA gains.
That makes sense, right? Specific location questions need fine-grained detail.
Exactly. Understanding those local features seems key for spatial VQA. Again, combining both encoders gave the absolute best performance.
Figure 4 had VQA examples too, I think.
It did, showing HSENet correctly answering some quite complex spatial questions. And Figure 5 gives a bit more detail, breaking down performance by body part using F1 scores. It does really well on stable, clearly defined structures, heart, lungs, breast.
But maybe less well on more complex shapes.
Right. The paper mentions it's slightly less optimal on areas like bone, which can have very irregular and variable shapes. And this raises an interesting point, maybe a direction for future work. Perhaps the way they currently divide up the 3D space, using uniform patches or voxels, might need to be more adaptive to handle those really irregular structures better.
Okay, so really impressive gains across the board. Retrieval, report generation, VQA, showing better 3D understanding. But the elephant in the room for clinical use is often speed. How fast is this HSENet?
Right. Efficiency is crucial, and this is where the numbers are, well, pretty stunning, potentially game-changing for workflow. The paper reports the inference speed. HSENet can generate a full medical report in just 3.59 seconds per scan.
3.5 seconds.
Yep, and it answers VQA questions in about 1.11 seconds.
Okay, 3.59 seconds per report. How does that compare to a human radiologist?
Well, the paper cites a study suggesting human radiologists take, on average, around 950 seconds per report.
950 seconds. That's like almost 16 minutes?
Yeah, 15.84 minutes, roughly.
Wow, so quick math? HSENet is doing the report generation task something like 260 times faster.
Around 264 times faster, based on those numbers, yeah.
That's incredible.
Think about the volume of scans in a busy hospital. A tool that can generate accurate draft reports or answer quick questions in seconds. It could dramatically change how radiologists manage their workload.
The efficiency gain is just astounding. Okay, so clearly a lot of strengths. What limitations do the authors themselves acknowledge in the paper?
The main one they discuss is that this work focuses purely on the information within the scan itself and its paired report. It doesn't currently integrate other really important clinical context.
Like what?
Like the patient's history, information from their electronic health record, EHR, maybe findings from previous scans or notes from clinical interviews. Real-world diagnosis isn't just reading the scan, it's putting those findings together with everything else known about the patient.
Right. The scan is only one piece of the puzzle.
Exactly. And omitting that broader context could potentially limit the system's reliability in really complex real-world clinical scenarios.
That makes sense. What about future directions? Where do they see this research going?
They point out a few promising paths. One is looking into ways to integrate maybe self-reconstruction of the 3D volume itself as part of the learner process alongside the vision language alignment. They also mentioned developing more adaptive ways to partition or process the 3D data, perhaps to better handle those tricky irregular structures like bone we talked about.
Okay.
And crucially, the need to collect and integrate more diverse multimodal clinical data, actually bringing in that patient history, the EHR info, to make these systems more robust and clinically grounded.
Right. Closing that gap with real-world practice. Okay, so let's try to wrap up this deep dive into HSENet.
Yeah.
What's the single biggest takeaway message for you?
For me, it's that this hybrid approach really seems to work. That combination of dual encoders getting both the big picture and the fine details, especially with that clever 2D guidance, plus the spatial packer that holds onto the spatial information, it feels like a genuine step forward. It directly tackles some core technical hurdles that have made it hard for AI to truly understand complex 3D scans like CTs with the kind of spatial nuance needed.
And the potential impact of making that step.
Well, the results speak for themselves, I think. The improvements in accuracy, particularly in clinical relevance for reports and spatial reasoning for VQA, coupled with that incredible speed, it strongly suggests systems like HSENet could become really powerful partners for radiologists.
Partners, not replacements.
Exactly. Tools that could significantly boost efficiency, maybe help catch things, and provide a sophisticated first-pass analysis.
It really does feel like we're moving towards AI that doesn't just process slices, but actually starts to see in 3D.
That seems to be the direction, yeah.
So it leads to a final thought for you, the listener. Given the speed and accuracy we're seeing from systems like HSENet, especially in automating time-consuming tasks like drafting reports, how do you think the role of the human radiologist might change in the next few years as they start working alongside AI like this?
It's a huge question. Will their focus shift more towards reviewing complex cases, validating the AI's findings, maybe spending more time collaborating with other doctors, or even directly with patients?
Yeah, could it free them up from some of the more repetitive work?
That's certainly the opportunity. Offload some of the high-volume, perhaps more straightforward interpretation, allowing their deep expertise to be focused on the most challenging cases where human judgment and integrating that broader clinical context is absolutely essential.
And what about the challenges? Ensuring that partnership works, building trust.
Absolutely critical. Trust and explainability will be key. Radiologists will need ways to understand why the AI reached a conclusion, not just what it concluded. Maybe the AI highlights the specific regions in the scan that drove its finding, and that human skill of integrating the AI's output with all the other patient information becomes even more valuable. It really points towards, as you said, a powerful collaboration.
A super-powered collaboration. I like that framing. It definitely leaves us with a lot to think about regarding the future of AI in medical imaging. Thanks for joining us on this deep dive.